I will say. This disease has done many things to you and will continue to do so. It has taken away so many different things. It has taken away your energy, your appetite, your ability to do these things. But what cannot ever be taken away is something within you, is the depth of you, is your life, your personality, your history, love, dignity, history, spirit. These are untouchable by this disease. And I think it's important to remind patients, not that patients need reminding, because time and time again there's an acknowledgement, there's a nodding of the head and say, I know what you mean. I haven't lost everything. I still have something at the core of me. So I would never say that this person has lost all dignity. Look at this undignified patient. That's something I would never say. Indeed, talking of the law, the international United Nations covenants that came through after the Second World War, each of them in their opening phrases, we the undersigned nations, acknowledging and respecting the inherent dignity of all human beings. The inherent dignity of all human beings. Other myths that sort of surround this debate is that, well, palliative care is so, really it's euthanasia by stealth, or there's aspects of palliative care really that is euthanasia. Now, as Greg quite expertly said there, language is all important here. And one of the myths about palliative care, and indeed euthanasia, is that a lot of things that are seen, oh, well, that's euthanasia, are in fact not euthanasia. So we need to be really clear about this. For instance, a patient who's been having blood transfusions to try and keep their blood count up, and it's becoming more and more difficult for that for the patient to come in and have those transfusions, or the effect of the transfusions is having less and less effect. It may be appropriate at that point to stop the transfusions and allow the disease to unfold to their death. Stopping a blood transfusion at that point is not euthanasia. Stopping intravenous fluids at a certain point is not euthanasia. A patient on renal dialysis who is now exhausted with this, who's had a stroke and is really struggling keeping going, who says, I want to stop my dialysis, and for that stopping of the dialysis, that is not euthanasia. So withholding or withdrawing treatment is not euthanasia. That's extremely important to note, because it can get all clouded over. Oh, well, look, the hospices are sort of doing this sort of euthanasia anyway, so why don't we make it legal? Absolutely not. What we are doing is we are withdrawing treatment when it is clear that that treatment is more burdensome than of benefit to the patient, when the disease process is unfolding to a point where the patient is soon to die. And that is correct. What we are doing is we're withholding and withdrawing treatment and allowing the natural process of dying to occur. Morphine. What a topic that is. Repeatedly, when we discuss about morphine, we have to calm everyone down. When we sit with patients, patients say, oh my God, are you going to turn me into an addict? Families saying, don't you start the morphine. I know what you're thinking, doctor. You're thinking Dad's dying. We don't think he's dying. Don't stop the morphine. Don't start the morphine. If you start me on morphine, doctor, I'll be drowsy and sleepy. I won't be able to drive. I won't be able to play with my grandchildren. Morphine. How could you start my mother on morphine? Those discussions certainly come into it. So let me just be very succinct here. The sophistication, the huge scientific advances that have occurred in the last 20 to 25 years in pain management have been extraordinary. Why is it that we feel pain? How do we synthesise the sense of pain? The issue of pain and gender, pain and culture, pain and society, as well as the very sophisticated transmission of pain signals, has been extraordinary. But not only that, the pathophysiology, if you like, of pain, but also the management of pain has become more and more sophisticated. We are not in the dark ages anymore. We are not in a situation where we've got no adequacy of good pain management. We're in a whole different situation here. And often that is not reflected in the euthanasia debate. If the debate simply puts or juxtaposes suffering which is unendurable and untreatable versus death, then of course people are going to say, I'm going to choose the simple option. But in that debate, how important it is that the third option, if you like, or the management, the meticulous, professional, clear-sighted, evidence-based management of these symptoms is brought to the fore and talked about is extremely important. Without it, we're missing out. Let's talk about a little bit about morphine. There are many myths about morphine, including many of the ones I've just said there. But in terms of pain management, in terms of palliative care and morphine, particularly in terms of cancer pain, day after day, dose after dose, we are aiming to use that morphine proportional to the pain. We are starting morphine, we continue morphine because of pain, not because, I think the patient's dying, so therefore let's escalate the morphine. It's simply titrated proportionally to the pain. We are not giving outlandish doses thinking, we're right on the borderline here, we may be giving such doses to reduce their suffering, but the patient may die. So, and we may or may not talk about the doctrine of double effect later. So I think it's really important that that's very clear. Recently I was appalled when a specialist, a medical specialist, not in palliative care, wrote a column in the Sydney Morning Herald, and he said, talking about death and life, every day in Australian hospitals, hospices and nursing homes, doctors commence morphine, increase the doses up and up until the patient stops breathing and then they die. And I thought, my goodness, what an extraordinary comment for a doctor to make. And how the public would pick up on that and say, oh my God, well it's all happening anyway, so why will we even, we better get on and sort of regulate and legislate. Absolutely not. The proportional use, it's proportionality. It's responding to the level of pain. That's what we're about. I might just close there by talking about perhaps, these are broader topics, these are huge topics, is the effect on society if we were to have physician-assisted suicide or euthanasia, and the effect on the medical profession. These are big topics and time doesn't allow me to go into detail about that, but they are very clear. Society would start to shift almost on its axis. The medical profession would start to shift on its axis if it were to be that this was legal. The medical profession almost certainly would be split if this were to come in. There would be some doctors who say, yes, I believe in this and this is what I'll participate in. And there'll be other doctors who say, I couldn't possibly be involved in this. And these are critical issues. So it's not just about the individual. It is about the individual at its core, but it's not simply about the individual. It's the effect of these profound changes on society and medicine. And also not only within medicine, but how the individual members of that society see doctors. How do they see a doctor? Because if they start to see a doctor in a way that's threatening, potentially moving on to something that's completely beyond what they wish, then we need to be very, very careful. So, I'm going to finish. And I'm just going to finish with a short story, or a narrative, if you like, drawn from my work. Words. I met her at the main hospital. She had metastatic colon cancer. She had received extensive chemotherapy. Her disease had progressed.